Me and My Prostate, a conversation with Chris Williams, Executive Director of Mind, Body, and Soul Incorporated, and also Dr. Randy Vince, Director of Minority Men's Health at the Cutler Men's Health of the University Hospital, cancer survivor Greg Archer, and cancer survivor Wayne Dancy. Please welcome our moderator, Mr. Christopher Williams.
So really wanted to dive in and talk about me and my prostate. With us today, we have an amazing guest, Dr. Randy Vince. Dr. Vince, I thank you so much for your time, for taking the time to get on with us and have this conversation. I mean, looking at your background, sir, Director of Minority Men's Health at the Cutler Center for Men at University Hospitals, and Assistant Professor of Urology at Case Western Reserve University. I mean, I could keep going, but I really would like you to tell the people about who you are, and let's just have a really free flowing conversation.
Yeah, absolutely. I mean, it's it's an honor and a pleasure to be here. Specifically around something that we're discussing, the disease that has really been near and dear to my heart, especially within my career. Because as a Black man, this disease impacts Black men disproportionately. So I'm happy to be here, happy to talk about this. Again, as a urologic oncologist, see a lot of prostate cancer, and there's a lot of misinformation out there. So happy to be here to kind of discuss the truth and help educate other men, so that way we can empower ourselves and take good care of ourselves and live long, happy lives.
Absolutely, and I appreciate that, and we look forward to that conversation. We also have a couple other survivors on with us. I'd like for you gentlemen to introduce yourself, and let's just let the people know a little bit about who you are. And I'll start with you, Ron.
Thank you, Chris, and thank you, Dr. Vince, for being a part of the program, being part of the podcast. And then I want to thank all of us, Greg and Wayne, for being a part of this. I am Ron Calhoun, the president of the Cleveland Observer and a 5-year prostate cancer survivor. And thank you all for being a part of the broadcast.
Well, good evening, gentlemen. And it's great to be here this evening with such a great group of men. So, my name is Greg Archer, and I am a survivor of 10 years, diagnosed on February 14th, 2013. And I remember that because I was out to dinner, and when I checked my voicemail to see, I saw the doctor called and left a message. So we're sitting at dinner Valentine's Day, and it says, "Hi, this is Doc so-and-so, and I just want to give you the results of your biopsy." And it was kind of one of those ones like, really? So, but through the grace of God, here I am 10 years later. I'm also involved in outreach with the Community Advisory Board over at Case Western and the CAP program. And I'm an educator with the Cleveland Metropolitan School District at my alma mater, which is John F. Kennedy High School. So it's good to be here with some of the eaglets getting ready to turn into eagles. So.
Okay, fantastic. Mr. Dancy, sir.
How are you? My name is Wayne Dancy, and I was diagnosed with prostate cancer in January of 2019. I had surgery that summer in June, and then last summer I actually had a reoccurrence. And in that reoccurrence, one of the things that I will say is my PSA post-surgery reached 394. And it took a long journey of multiple scans, and eventually an MRI discovered the reoccurrence, and then we had to have radiation. So as of the last, 8 months or so, I'm considered, PSA is undetectable. Praise God for that. But it was a very long journey in that process. So, and I know Ron and Gregory from our church affiliation, and I look forward to tonight.
we're grateful to have you three gentlemen here to really share your story. And Mr. Dancy, sir, we're grateful to have you here, considering what you just shared,
Praise God.
especially. So yes, absolutely, praise God. I'm going to dive in, and Dr. Vince, I kind of want to, just follow up after what Mr. Dancy just shared, with a PSA level that high, and really get into what prostate cancer is and why, why is it so prevalent among us as Black men?
So, I guess to talk about what prostate cancer is, we first need to talk about what exactly is a prostate anyway.
Yeah.
Because I think most people, as you grow up, I have a liver, I have a heart, I got lungs, but these smaller organs of our bodies, like the prostate gland, we don't really hear about a lot until we get older. So a prostate, all it is a small gland that's part of the male reproductive system, right? So it helps when men have semen. It helps provide nutrients to the sperm so that way it can ultimately try to reach the egg and fertilize. So whether it's making sure that the fluid is the right pH and not trying to be all sciencey or anything, but whether it's that or providing certain minerals to the fluid, the overall goal is for it to help the sperm reach the egg. So that's what the prostate gland is in itself. And then, of course, we all, growing up, we hear about cancer, and we know that that's just an abnormal or alteration of the normal tissues that cause it to grow rapidly. And so that's what prostate cancer is in a nutshell. There's many theories that have been floated out there about why prostate cancer is more prevalent in Black men. When I was in medical school, it was taught that there was just something innate about the biology of Black men that caused it to be more prevalent. There's been billions of dollars of research that's been put forward, and there is no innate cause that we can identify. So there's nothing specifically inherently wrong or per se with a Black man that predisposes him to be at increased risk. However, prostate cancer tends to be more of what we call a chronic disease. So, there are life experiences that a lot of Black men have that are similar, whether it's, chronic stress or environmental exposures that lead to more chronic disease. It's no different than diabetes or hypertension, and prostate cancer kind of falls in that same realm.
Interesting. It leads me to wonder if it's really an issue of prevalence or more so just the fact that we unfortunately catch it a little bit too late, due to maybe lack of doing the necessary testing, lack of education, access to resources, and so forth.
Yeah. So, that's a great point. Because, the prevalence, there is a slight increase in prevalence when it comes to Black men compared to white men, so to say, if we make that comparison. But Black men are over twice as likely to die from prostate cancer compared to white men. And so, when you put that together with knowing that if you catch prostate cancer when it's confined to the prostate and you manage it appropriately, at 5 years, nobody should be dying from prostate cancer, right? So when if it's caught early and we treat it like we're supposed to, that no one should die from this disease, but yet Black men are twice as likely to die from this disease, then it does lead to we're not undergoing screening like we should. And that's for a number of reasons. I could get on my soapbox and talk about that all day. But in addition to that, the screening not taking place like it should, and then ultimately the disease being diagnosed at a later stage. And then take that one step further, there's also evidence that Black men are not offered the gold standards of treatments at the same rate as others. So all of these things combined ultimately lead to that disparity that we know exists with the number of men that die from prostate cancer, specifically Black men.
Yeah. You know, a good friend of mine is on, and he just raised a point. He's also a doctor, an internist, Dr. Maurice Hinson. And he said the guidelines don't adequately account for the risk of prostate cancer in Black men. What are your thoughts?
You know, I think, and I'm actually, I've been actually kind of outspoken about this because the guidelines have been all over the place, to be honest with you. You know, there was back in 2012, the national guideline organization called the United States Preventative Service Task Force changed the recommendation and actually recommended against men being screened for prostate cancer. Then in 2018, they changed it back. And then you couple that with, you have all of these prominent organizations that say, oh, well, if you're Black, you should start at 40, or you should start at 50, or you should start at 45. And so there's been no consensus across the board amongst all of these organizations that are very respected about when you should start. And so, you know, there are a lot of, and I give talks to other primary care physicians, there's some who haven't really been tested men with their PSA to screen for prostate cancer. There's some who say, oh, well, I looked at this guideline and it said 55. I looked at this one, it says 50, and I don't really know what to do. So, you know, and I was recently on the guidelines committee for the Prostate Cancer Foundation. And this is one of the points I raised. It's like, you could put out guidelines all day, but if it's all of this information is conflicting, it just adds an extra layer of complexity that shouldn't be there.
Absolutely. Now, you mentioned something that I want to explain. I want to ask you to explain a little bit is PSA. What is PSA, and how does that impact whether or not you are at risk for prostate cancer?
Yeah. So PSA stands for prostate specific antigen. So this is a protein that we could test the level of that is secreted by your prostate. So the prostate, again, is a gland. So glands secrete things no different than other glands in your body. So this PSA level, usually depending on, you know, the range at the facility where you have it tested, kind of ranges from 0 to 4. And what we know is that there's an increased association with an elevated PSA and the formation of prostate cancer. So does that mean that if you have an elevated PSA, you definitely have prostate cancer? No. But does that kind of raise suspicion that there could be potential prostate cancer there as it continues to go up? Or if it's elevated, yes. And so that's kind of the test that we use now to detect, or to start the process of further evaluating somebody more completely for looking for prostate cancer.
Now, is it necessary to do, so from what I understand, you can do a PSA blood test or you can do a rectal exam, correct?
Yeah, so I'm glad you mentioned that, because, you know, that has been a point of contention for a lot of people because,
oh, yeah.
You know, there's been some old data that shows that, you know, when you start talking about a digital rectal exam and, you know, the thought of, for a man, of having somebody stick a finger up their butt or anything like that, like, it discourages people from being screened. And what we know is that it can be helpful, but in the long run, it doesn't add that much to the overall process of detecting prostate cancer. So, you know, that's like something that you should talk to your physician about. It's not absolutely mandatory that you have a blood test plus a DRE. You know, in the way I look at it, if we could screen all men with a PSA, I would be over the moon. I would be so happy about that, because we would, you know, detect cancers much earlier. And again, we would save a lot of lives. So men would be cancer survivors rather than dying from this disease.
Absolutely. Now there is something that I recently experienced through my dad, where he had a prostate exam. My dad is 76. Just a little background, very active. He cycles, he plays golf, you know, had a hip replacement a few years ago, and the man is like bionic man. He won't stop. So he had, his PSA levels were high. And so they gave him, the person who called him said, "Oh, you know, we need you to come in. We think there may be an issue." But he had seen his doctor prior to this and was aware of the elevation in his levels, and it was within a normal range. Talk to me a little bit about why that could happen based on age, based on level of activity, that sort of thing.
Yeah. So, one of the things I tell a lot of my patients is, if you're blessed with the gift of longevity as a man, you're going to deal with prostate issues. It just, it varies on what type of prostate issue you're going to deal with, because what happens is, over time, testosterone being that male hormone, it will cause the prostate to enlarge. That's for everybody. And then there's a portion of men who, in addition to that enlargement, will have prostate cancer that forms as well. So given that we know that that's the case, your PSA in your 30s is not going to be the same as your PSA when you get into your 70s, right? And so because we know that, we start to take that into consideration. Now, that doesn't mean that if you have a PSA in your 70s, you have a PSA that's 30 something, that's not concerning. But as you get older, if your PSA, we talked about the range 0 to 4, if it's about 5.1 or 5.2 and you're almost 80 years old, we're not looking at that necessarily the same way as we would if you were 52.
Understood. So the bottom line is there are indicators that would lead people to make certain assumptions, and what really should be happening is, hey, if your levels look higher than they should within a certain age group, it should be, let's come in, let's do further testing and make sure everything is okay.
Yeah. And the other thing is, and I can't emphasize this enough for other physicians or just my patients in general, your PSA level can fluctuate some. So we need to look at a trend. So one number should not, necessarily dictate everything, right? So there's no one that I've ever treated for prostate cancer that only had one PSA result. That's just not the case. So those PSA numbers should be trended. And if we see a persistent rise in your PSA numbers, that is more concerning again for prostate cancer.
Okay. What are some of the symptoms? And I'm sure our survivors can dive in, and I'll allow you gentlemen to step in and share this as well. But from your perspective, Dr. Vince, what are some of the symptoms that men should be looking for when thinking about prostate cancer?
Earlier when I alluded to how prostate cancer was, to me, lumped in towards a more chronic condition like diabetes and high blood pressure, I said that intentionally because, usually if the cancer is confined to the prostate, so it's not advanced, there aren't really many symptoms, right? You might have symptoms from the enlargement of the prostate, but symptoms specifically related to that cancer are not necessarily there. If because there are a lot of men who have prostate cancer who don't have urinary symptoms from prostate enlargement. So just like diabetes, high blood pressure, usually when you start to have symptoms like urinary issues or blood in your urine or bone pain or those types of things, the cancer is usually more advanced. Just like, if you have complications related to high blood pressure, like blurry vision and things like that, it's because your high blood pressure has been high for a while and it's, hasn't been checked. And so this is typically what we see a lot of times for prostate cancer. For instance, I've had men in their early 50s who have had prostate cancer who came in, had their PSA checked, and they were like, I feel perfectly fine, right? And if they had not had that PSA checked and just waited until they started to feel symptoms, then that disease would have gone from a disease that was potentially curable to a disease that we just try to keep at bay.
I'll start with you, Mr. Dancy, since you were the last person to speak. In terms of from the perspective of a survivor, what were some of the symptoms you experienced, or did you experience any symptoms at all?
On my initial diagnosis, I didn't experience any symptoms related to the prostate. I actually was shocked when I went in for an annual physical. Now, I had a general level of fatigue, but it turns out I had a number of things going on, but nothing specific to the prostate until the doctor indicated, based on my initial PSA at that time, which I think was just under 11, and a digital exam where it was enlarged, but nothing on a day-to-day basis that indicated I had a problem. Now, in my reoccurrence, I did run into some issues.
What were some of the issues, if you don't mind sharing?
I had a constant state. I couldn't sit for length of times because I had a constant. What am I trying to say? I had a constant state of irritation down below. Unable to sit, unable to find a comfort zone. Even my pants, I had to be careful how tight or anything I wore my pants or things along those lines. But that was in my total journey, which roughly about 5 years. That was about a 3 or 4 month window.
Wow. And now everything is good.
Yes, right now. Yes. Knock on wood.
Fantastic,
Yes, it is.
Fantastic. Greg, Mr. Archer, sir, what if you can speak to that a little bit and share your experience.
Well, as far as I did have a symptom that brought it to my attention, which was hematuria. So I had some blood in the urine. And so I initially went to Cleveland Clinic, and I saw the urologist there, and I said, at that time I was a 52-year-old male, 53. And I said, so here I am, I'm having this issue. Can you give me some idea what this could be? And to my chagrin, what they ended up doing was having a cystoscopy to look and see if I had bladder cancer, okay? Which is not it's kind of like it's a lot more invasive than a PSA or a DRE. So anyway, comes back and said, no, you're good. And, there's nothing detectable there. So anyway, I kept going on, I'm going on with my life because I had no symptoms physically, like in terms of fatigue or discomfort or anything like that. So then it continued. So I say maybe almost a year later, it was off and on. And I went back again a year to 6 months later. And I saw the same guy, and he did the exact same procedure again. So then I'm sitting up in my primary care's office, and I'm thinking about this and saying, okay, well, what was my PSA? And he looked at my chart because, I'd been seeing the same providers at the same healthcare system, the entire process, so they could see the results. But he said, there's no PSA. And when I went back, again, he said, do you want one? And I said, yeah. So that's when it came back 7.8, and which led to everything else. But as far as like fatigue or anything like that, always been active, exercise, move around a lot, have a lot of energy. And that's pretty much been the case. Now, I did have a reoccurrence also, and which I noticed a trend, like Dr. Vince said. So, for the last 10 years, I was at point. It was kind of stable at 0.03. And so that was considered fine. And then it started going up, it quadrupled. It was like at 0.0, it was 0.12. And it continued on for some months. And then we found out that it had moved, and I had a small nodule in my lung. Okay. So what happened with that? We did something called SBRT, which is a focal radiation. It was 5 treatments. And then, thank God, I came back undetectable, less than, you get that, when you look at the chart, it says less than, 0.02. I was like, okay, here I am. I'm back in there again. So yeah. So that's my diagnostic journey, I guess, if you want to call it that. And it was challenging. And I think for me, that's important. What I learned from that is we really need to be educated as much as possible on what the options are, what these procedures and exams mean, because if you feel uncomfortable asking questions, and if you feel uncomfortable doing the research, maybe somebody should be provided to be available, so that it can explain that to you, because it's still your decision no matter what. But I'm going off a little bit of a different topic. So yeah, but that was my thing.
Not at all. And you raise a point, and I know Dr. Vince will speak on this as well. The importance of us learning to advocate for ourselves. It's something we talk about all the time. I talk about when I have conversations like this, because were you not educating yourself, and if you hadn't raised that point and say, hey, what's my PSA? Where would you be today? So thank God you thought to ask that question and say, hey, let's look at this, because this is why education is needed. This is why these conversations are crucial, to ensure that people understand the message, the importance of you learning. We only have one body, just one, no other one that we can rent, borrow, steal, anything like that. So we've got to make sure that we do the due diligence to understand how that body works, how to take care of it. And when there are issues, sort of, not necessarily get into a self-diagnosis mode, but at least be aware that you can ask the doctors the questions they need to answer. Dr. Vince, thoughts around that. And Ron, we're going to get to you, because I want to obviously hear your story as well.
Yeah, no, I couldn't have put it more eloquently. I think this does highlight why events like this are so important. Because, I'm a big believer that knowledge is power. And so by continuing to have events like this, where we educate ourselves about different health topics, we can now empower ourselves to take better care of ourselves, right? So I think, I couldn't agree more about that. And, as I was sitting here listening to that, I start to think about, some of the times where I've seen patients, and as a physician, I'm literally questioning, like, what was going on with this? Why had this patient not been screened for prostate cancer prior to coming to seeing me? And one of the things that stuck out to me was, I had a guy who was 63 years old. He was referred to me because he said, I feel like I'm urinating a lot at nighttime. And so I said, okay, well, I ran through a whole list of things that could be causing you to get up a lot at night. And then I said, as he was leaving, I said, I noticed in your chart you haven't had a PSA exam before, or a PSA test before. I think we should get one. And his came back, his PSA was in the 30s. And that set off a whole cascade of testing, and he had prostate cancer that had started to extend towards his rectum. And if we had not intervened in that time period, this could have very well spread into other organs of his body. And, who knows how much longer he would have been around, right? And so this is, again, and he had never heard, he went to the doctor every year, never knew anything about PSA testing. And so he had confidence in his physician that, that everything he needed to be screened for, that they were doing, and they weren't. And so, again, that just highlights why it's so important to have this knowledge.
We know that if caught early, all right, prostate cancer is treatable. We know that if you have a history of it in your family, that you should be getting tested earlier. I've heard that 40 now is the age that they're testing Black men. Again, like you talked about the guidelines, Dr. Vince, they keep changing, right? So what are some of how do we push for change in these guidelines to ensure that, testing is not just what they say, meaning, whether it be the AMA or whatever governing organization that makes these rules?
So there's a little bit of an issue with a lot of these guidelines and the numbers that they throw out. And the reason why is because all of these guidelines are supposed to be based off of research. And what does the research show? And so while the research shows that there is an increased prevalence of cancer formation in Black men, there's no research that shows that if you start screening Black men at this age, particularly, that you start to catch all of those men. And the data that does exist is based off of people using other data to model what they think would be the best age. And so I think that's part of the problem. But regardless, when the guidelines were consistent for all men and didn't adjust for your race at all, we still were not screening Black men at the rates that we should have, right? And so when they said 55, the rates of Black men being screened were substantially lower than other races. When they said 50, it was substantially lower. And so one of the things that I've been very outspoken about is, okay, yes, we can lower the age for Black men, but if we're still not screening, it doesn't matter whether we lower the age to 35, right? Like, because it's still not being done. So I think the effort should be more focused on making sure that we are screening Black men, that all primary care physicians know the importance of PSA screening. And, you know, to me, just being honest and transparent, I could care less about the age, whether, you know, we could debate all day about whether it should be 40, 45, 50. I could care less as long as men are getting screened.
Absolutely.
That's the biggest problem. So, you know, there are studies that show that Black men will form prostate cancer early, but all of those studies on average show that it's occurring in their 50s. So, you know, so to be honest with you, I just think it's important, you know, to really get more men screened, more than anything else, more than changing the ages or anything else.
Understood. Mr. Dancy, you were going to say something.
Yes, I wanted to agree with everything Dr. Vincent said. But we have to really start to educate our men and our single and our mothers, because at my age, I had no idea, about the prostate. I often tell my wife, I know more about your body than mine. And that's an embarrassment, but it's the truth. I was raised without a father. I had no clue. I'm in my 50s and I had no clue. You know what I'm saying? And my first prostate PSA test I took when I was 50, and it was in the 3s. Had I known what I know today, I, number one, would have had that test taken, let's say 6 months later, and start to track the trend line. It was a 4-year window before I had it taken again, and it was, you know, over 10, right? But I understand today the importance of that trend line, and I understand the importance of following up. But to be absolutely truthful about it, I had no idea. So once I was told about this PSA, I mean, I went to school, correct? I pretty much read anything I could read, and thank God also there were people around like Brother Greg Archer and others that helped educate me. But I, as a grown man, knew nothing about my prostate, did not understand its importance. And again, I knew much more about a female body than my own body. So educating the general population of men about the necessity of us participating in this type of screening, as well as, you know, let's face it, the reality of our culture today, the women that are raising men, the same. That's what I wanted to add to that.
Yeah, so you know what that leads to is the fact that we need to normalize these conversations. These conversations here that we're having with people like yourself, Mr. Dancy, Mr. Archer, Mr. Calhoun, you know, and you, Dr. Vince, leading this in terms of your knowledge as a urologist and urological oncologist in this space will make a difference. So these are conversations we just have to keep having, and we have to keep, like you said, pushing for our men to get screened. And I'm going to focus specifically on Black men because I think we need it the most. And from what I hear, and Dr. Vince, you can speak to this a little bit more, the numbers in Cleveland, you know, are there's a lot of disparities among Black men in Cleveland that need to be addressed right now. Is that correct? Is that a correct statement?
Absolutely. And this is another thing, and I could talk about this for hours, because there is a overarching systems issue when we talk about the lack of screening that is impacting Black men, not only in Cleveland, but in a lot of predominantly Black cities across this country. The disparities that you see here in Cleveland, you'll see it in Detroit, you'll see it in Baltimore, you'll see it in Philadelphia, you'll see it in Louisiana. You pick
in Brooklyn, New York, where I am. Right?
Exactly. You'll see it in New York. Pick a city and you'll see those same disparities, right? And so, again, that just points to the importance of educating ourselves. And this is part of my mission, as with my career, and one of my personal passions is because I know for a fact there is nothing wrong with Black men, right? And I'm saying this as a Black man myself, but it's hard to know what to be tested for if you're never taught, right? It's hard to know exactly what you can do to prevent certain diseases from occurring if you're never taught. And then if the healthcare systems that we're relying on are perpetuating the issue around, lack of screening, inadequate access to screening, or, disparities within the treatments, then, it's even more important for us to have that education. So that way we can, like we talked about earlier, start to advocate for ourselves.
Absolutely. Mr. Archer, go right ahead, sir. I see you have a question.
Yes, thank you very much. And you guys made me consider another point in my experience, and that's being able to advocate also and make a decision not to do some things. So my case in point in this is, in this reoccurrence situation, as I noticed the trend, there's other procedures and tests out here that are more precise, such as a PSMA, which, highlights receptors, and it just gives you, more precision medicine. So anyway, when we all agreed there was a trend and it wasn't stable, I said, okay, let's do the PSMA, because the recommendation was, since we don't, obviously when that happens, you start to get scanned. So they send you over to nuclear med, you get scanned, and they say, okay, we're just looking for everything. But there's more precise with the PSMA. They didn't want to pay for it. Okay. And they wanted the PSA to continue to move forward in that trend. But in the interim, they suggested that I take something called salvage radiation, okay, which means they'll just kind of directly go at one area. And I said, well, no, I'm uncomfortable with that because, first of all, my PSA now is like 0.18. It's not like skyrocketing. So, and it probably grows pretty slow. Let's get this other test first. And so we had to do a peer-to-peer review. I had to kind of motivate the doc to go ahead and do that because, and I understand, everybody has a job and people don't feel like filling out a lot of extra paperwork and making calls to insurance companies and everything else. But it's like when it comes to the point where you're trying to make a decision like this. So thank God it finally got approved, and it turned out there was absolutely nothing in the prostate bed or that area where they were going to do the salvage radiation. And it was just a very small, very addressable situation, which didn't take a lot out of me. So I guess bringing it back to the point is, that sometimes it could be so complex that you need to advocate for yourself in certain ways that if you don't, you might end up having a procedure that doesn't provide the benefit, that you think is going to get. And I will kind of leave it at that one there.
And I'm sorry, I want to jump in on that because my experience, I'm agreeing with Greg on this, but I had 11 scans post-surgery, bone scans, MRI, CT scans, and 3 PET scans with 2 different dyes. The most current, which I think was approved in December of 2020, I forget whether the PMA, and they all came back negative, detections negative. it actually took an MRI for them to detect the reoccurrence. And that was the 12th scan that I had. So, who knows why? I mean, I was told that there are certain prostate cells that don't light up with the PMA. And eventually it was a standard sugar scan. I tried that. I mean, we tried a little bit of everything, but for 3.5 years, none of the modern approach to it. It really came down to an old fashioned, a tumor had to be shown to detect it in my body. And it caused great consternation amongst the doctors. And there was an interdisciplinary board that looked at my case on several occasions, because my PSA went all over the place. It was in the hundreds for multiple testings. So, but you do have to learn the language, and no disrespect to any doctor, you got to learn to challenge them, because only you know your body.
Well said for you, Mr. Dancy and Mr. Archer. I definitely don't think it's a disrespect, and I think Dr. Vince will agree. Doctors should be challenged, right? You want to be challenged. You don't want your patients to just sit there and go, yes, yes, yes. So I'm going to let you go ahead and
no, absolutely. And I've said this, when I go out into the community and I give talks and everything, and people ask about that, I say there's a couple of things that I always try to accomplish, especially if I have a patient that has any newly diagnosed cancer, right? So one is the word cancer is anxiety inducing. So I want to kind of take that away from them, right? Especially when it's a newly diagnosed prostate cancer that is confined to the prostate. I want to take away that thought of, I just heard cancer. Do I have to get my affairs in order because I'm only going to live 1 year, right? Because we're kind of trained almost to think that. So I want to take the shock and awe out of the conversation. Then I want to explain exactly what is going on with their body at that particular moment, right? So what is the stage? What is the grade of the cancer and all of those things, and make sure they really understand that. And then, I run through all of the different management options, because, believe it or not, I like to simplify it and say there's 2 buckets that you can fall into when you're diagnosed with prostate cancer. Some men will have a very low risk or non-aggressive prostate cancer that we don't even treat. We just watch. And if it starts to progress, then we do something about it. But if not, then, we don't do anything. So, you might fall in that bucket. And what do we talk about in terms of the active surveillance and how we monitor it? Or you might fall in the bucket where treatment is beneficial. And I'm going to run through all of the different treatment options. As a surgeon, I know the most about surgery, but I send all of my patients who have been newly diagnosed to see a radiation oncologist, to see a medical oncologist. I want them to have as much information as possible, so that way when it's time to make a decision, they can make the most informed decision that they can. And then the last thing, I always ask, do you want a second opinion? Because as a physician, I feel as though, and most of physicians should feel this way, if you're telling your patient the right thing, when they go to get that second opinion, they're just going to reinforce everything you already told them anyway. The only way it will be differing information is if you're not telling your patient what they should be, the information they should receive. So I don't take offense to it. I actually ask all those patients, like, do you want a second opinion from another urologist? You're going to see a radiation oncologist. You're going to see a medical oncologist. Get all the information from them. And if you want to see another urologic oncologist like myself, I will happily make the referral to them and give them all of the information that I have available to you. So if you run across a physician who takes exception to you challenging them or asking for a second opinion, you need to go see another physician, in my opinion.
Yes, I definitely agree with that. I wanted to give Mr. Calhoun, Ron, an opportunity to jump in, because we didn't get to hear from you, Ron. And I know you raised a point. Is there anything new coming to treat prostate cancer. But Ron, you go right in and let's. I want to hear a little bit more about your own experience.
When I first got diagnosed, it was purely because of my brother. My brother was diagnosed with it, and he kept telling me, "You need to go get yours checked." You need to go. I had absolutely no symptoms, and even up to this point, I haven't had any symptoms. And I fought it myself for probably almost a year. And I saw him going through the radiation, and I said, you know what? Let me go ahead and get this done. And lo and behold, my numbers were high. I think they were at 5.9 or 5 something. It was in the fives, and it really surprised me. And you're absolutely right, doctor. The first thing you start thinking is, do I need to get my affairs in order? Am I going to die? And it becomes real fast. And that was my journey. And from that point on, I ended up actually uh, embracing it and just doing everything I was told to do, all the way up until the time to select a treatment. And then it got a little dicey. And if you want to talk about that, we can, but I'll back off now.
No, go ahead, Ron. You had a couple of questions, so I really wanted you to get a chance to dive into some of those.
Thanks, Chris. My experience has been unique that I learned through my brother who had prostate cancer and kept urging me to go and get a test, go get a PSA test, just to have the confidence of knowing that you either have to deal with it or don't. And I wasn't having any symptoms. I didn't feel any certain kind of way about it, and it seemed to me at the time that it was a waste of time. At his urgings, I went on and finally got the test, and lo and behold, it was high. The numbers were 5.9. And that started a whole process of examinations and MRIs, and then finally the decision to select a treatment. And my doctor was an old school surgeon, and I found out that robotics was a technology that was less intrusive and could heal faster, and it was more precise. And once I told him that I wanted to have that type of surgery, he referred me to another doctor and basically dismissed me. And well, that's another story. So if you want to hear more about that, let me know.
Dr. Vince, first, what are some of the new methods of treatment out there for prostate cancer? And then obviously, alternative medication. Are there other things that we should be looking at when treating this? And then I would like to dive into, obviously, for you to comment on what Ron just said and dive into some of the myths before we leave.
Yeah. So there are different treatment options that are being researched right now. The issue is the data around a lot of these treatment options are it's still not there yet. So it's hard to fully promote it because the actual disease-free, what we call disease-free or recurrence-free survival, the information around that is not where we want it to be, especially knowing that we have these other methods that are really good, right? So things that I'm thinking about are what we call focal therapies, where and then you have to fit in a certain category of disease where there's only one focus of cancer for these focal therapies, and the goal is to go in and either with a very high intensity ultrasound or a freezing needle to kill off that tumor tissue and leave the rest of the prostate intact. But again, the long-term data, which is what we really worry about, is just not there just yet. So, so that's a newer technology that potentially down the road could, be very impactful, but we don't know just yet. In terms of alternative medications, again, there's been some things that are floated, but the data just doesn't support it to where I would feel comfortable recommending it to anyone. So I'll leave that there. In terms of, the experience, Mr. Calhoun just talked about, I at loss of words because, one of the things I tell all my patients, regardless of if you get surgery as a surgeon or you get radiation, I tell them, I said, whether you like it or not, you're going to see me a lot because, I'm going to continue to follow up with you. I'm going to make sure that nothing falls through the cracks. I do that because there have been patients that I've seen that were treated for prostate cancer. PSA was undetectable. Nobody checked it for 10 years. And then all of a sudden, it's over 10. And then they have a disease site on their ribs or something like that. And, the devastation you see on a man's face when he's like thinking that he was cancer free. And now all of a sudden you tell him, no, you have a disease recurrence. And it's all because somebody didn't check the PSA levels and, it just fell through the cracks. I never want to see that. So I tell everybody, I was like, I hope you don't mind seeing this mug because you're going to see it a lot because I'm going to be there with you every step of the way.
So the bottom line is, as we go through this, and I know we're going to be wrapping up very shortly, but it's very important that, we do the due diligence when we're looking for doctors. It's very important that, we date our doctors the same way we date in relationships, right? The same way we court relationships that are business, personal, whatever, because, we want people to care the same way we care. And then it's also very important that we continue to ask questions, no matter how painful they may be, or no matter if you think they're going to offend the doctor. I mean, dare I say, damn the doctor. I mean, not in that sense, but it's about you getting the information that you need. Mr. Dancy was asking if urine testing for prostate cancer is effective. I wanted to get that out before we get into some of the myths. Dr. Vince, is that an effective test?
Yeah, so there's been some tests that what they do is they look at the urine to determine if someone has the likelihood of that clinically significant prostate cancer. So remember I talked about the two buckets, or whether they have the bucket, they fall into the bucket that would need treatment. It's not routinely used, and it doesn't, give any long-term information on how you would do with different treatments or anything like that. It's just that this a higher test, urine test, based off of how they score things, is associated with an increased likelihood of having fallen into that bucket.
Okay.
But it's
Before we
not
go,
prostate cancer. I want to make sure we put that out.
wait, say that again.
Does not diagnose prostate cancer though. So
Okay.
you can have a higher result and not have prostate cancer as well. So I just want to make sure that we put that out there. Outside
Absolutely.
of having extremely elevated PSA or having tissue, we can't say definitively that you have prostate cancer.
So right now, a PSA, and then I think the PSMA, correct? Is that what I believe Mr. Archer mentioned he did? And of course a digital rectal exam. Those are the three more prominent tests or prevalent tests that are being utilized at this time?
So I think I should classify this. So PSA plus or minus a DRE. That's a decision. The DRE is a discussion you should have with your physician. Right. Those are the things we use to screen for prostate cancer. The PSMA scan, that scan is for helping to detect if there's disease recurrence or if we think that cancer potentially has spread outside of the prostate. So that is more of a whole body scan, and it's really sensitive at picking up prostate cancer cells to help identify if it is spread to other parts of the body, where it's located.
Okay. All right. Listen, we've had a really good, a robust, I think, conversation and discussion around prostate cancer, your experiences as survivors, gentlemen, you, Dr. Vince, as, someone who's been treating and helping and really evangelizing the importance of awareness in our community. And I know there are a bunch of myths out there. I want to try to dispel as many of those as we can as we educate. And what are some of the things that you've seen? I'm sure the gentlemen who are survivors have heard some as well. I'd love to hear from you what those are so we can dispel those myths and get people to take this more seriously.
Yeah, well, the one that I kind of harp on, and you see that I keep saying, the DRE is a discussion you should have with your doctor, because I've heard this several times where men feel like, oh, I don't want to be screened for prostate cancer because it might impact my masculinity. I don't want anybody putting a finger up my butt. No, I've heard that so many times. And I say, well, we could just do a blood test, just like you get anything else checked, like your cholesterol or your blood sugar. So we could just do a simple blood test. Would you be okay with that? Yeah, that would be fine. Well, that's really what we're using to screen anyway, right? Like, so if we could demystify prostate cancer screening equals demasculinizing someone, then I think that would go a long way, specifically for Black men, getting screened for prostate cancer.
Yeah, I agree. Ron, Mr. Dancy, are there things you experienced before, Mr. Archer, in terms of myths that you heard about prostate cancer or getting screened that maybe left you feeling a little uncertain about whether or not you wanted to move forward?
The last piece I was going to say is dispel the myth that you can't get back to your normal behaviors. You got the extremes. People do go through it and they can't be themselves what they were before. But then there are people that have come back 100%. I can honestly say that I'm back to about 85, 90%. And that's being totally transparent. And I'm comfortable with that.
And if I could just interject really quick, I know we're short on time. One of the other things is, as physicians, it's our duty to make sure that patients understand everything going into treatment. And the reason I say that is because, if you are just throwing it out there, in your 60s, and before your diagnosis, you struggle with erections and you have erectile dysfunction, after your diagnosis and treatment, you shouldn't expect it to go back to how it was when you were 20 years old, right? So what you come in with greatly influences what you leave with. And I think we have to be very honest and open about that, because I have had men who have very poor erections before surgery or before any treatment, And then after the treatment, it's like still very poor. And they're like, oh, the treatment did it. No, the treatment didn't do that. It was already poor. So I think that's also something that we have to make sure we're very cognizant about when we have these conversations.
Absolutely, absolutely, and we again have to be more open, in our conversations with our doctors, because then we won't have these high expectations if we share a little bit more. But that's another conversation. Erectile dysfunction is a totally different topic that we definitely need to dive into. And Dr. Vince, I may call you back. Myself and Ron may do something again with you on that subject. So gentlemen, I know we're going to wrap up. Are there any closing thoughts? And this is specifically to our survivors, Mr. Dancy and Mr. Archer and Mr. Calhoun. Any closing thoughts before we wrap up?
I think, I would like to suggest that, one of the things that when I look at different treatment options available for survivors, and I know we have a lot of different opinions. We did a listening tour at Case, and I got a chance to hear a lot of different perspectives about prostate cancer. But one of the things that I would hope, that we would consider more is genetic testing, and to kind of look at where we are, because I think a lot of these treatments, a lot of these drugs, all these things are being developed, and we don't participate in the clinical trials. We don't participate in, so we have no idea what kind of efficacy our population has. So we need to also consider that. I mean, because we have some myths like, I'm not giving up my DNA, they're going to clone another me, or they're going to, whatever that might be. But it would definitely help perhaps save some lives.
Yes. Mr. Dancy.
Yeah, and I guess again, my point is we need to educate. We need to educate and inform as much as possible. I'm for screening as early as possible. I mean, blood tests that's painless, right? You don't have to do the digital with the blood test. And as much as I wanted to dismiss the PSA at one point after so many screenings and not getting an answer, I really found that it's directional. It gives you information that tells you whether I had high risk. I was a class 5, I had a 9 Gleason. So, they're telling me I was in that bucket you got to do something about. We must educate and inform men and mothers of men.
Agreed. And listen, if you're up to it, we may need to take this on the road, right? I'll come out to Cleveland. I'm in New York, but I haven't been to Cleveland yet. And I said it to Ron, I'll say it again. When you want me, I'm on a plane. I'll come out there. Ron, please, I'd love for you to wrap up with your thoughts as well.
Here's the bottom line. Go get tested. Get a PSA. Go through that process so you know. Other than that, I just want to thank Chris Williams as the Executive Director of Heart, Body, and Soul, and Associate Publisher of the WherItzAt magazine in New York City. And of course, our guest speaker, Dr. Randy Vance, he's the Director of Minority Men's Health of the Cutler Center at UH Hospital. Thank you both so very, very much. Really appreciate you being a part of the team and giving us this information that we need to spread across our community. Thank you. Cleveland Observer owes you, so anytime we can help, let us know.
Dr. Vince, thank you. Thank you, of course, to our survivors, because really this would not be the robust conversation it turned out to be without you gentlemen. So thank you, Mr. Dancy. Thank you, Mr. Archer. And thank you, Mr. Ron Calhoun of the Cleveland Observer. And thanks for making this possible for us to do. So I really appreciate it. And Devin Jones, who's on the call, who's very quiet, hasn't said a word. Thank you, brother. I really appreciate you for making this all happen, because you were the architect behind the scenes making magic. Dr. Vince, any closing thoughts? I'm sure you have a few. You and I are going to definitely be fast friends. So we'll talk.
Yeah, no, I think again, and this is just reemphasizing many of the things you just touched on. You know, I enjoy having these conversations, and I think it's extremely important to have a patient perspective, right? And so, whether you name the program, if there could be a gathering of men where we have these open, candid conversations and educate ourselves, and I think we ultimately the impact we can make it will be so great. So I applaud you guys for putting this together. Please know that I'll be here. And if you ever need me, just call me. I'm not one of those type of people where I'm like, oh, you gotta pay me anything. I'm like, no, if it's in service of our community, I want to be there. So please know that you can call on me at any time.
I appreciate it. I appreciate it. I'm definitely gonna bring my brother Dr. Henson down so you can meet him as well, because I'm sure you guys will share a lot in common as well. And thank you again. Thank you all for everyone who joined, who listened. Please, this is going to be on YouTube, correct, Ron? So you can share it. I encourage you to share it with your brothers. As Mr. Dancy said, share it with the mothers. Share it with everyone, all right? Because this is going to be on YouTube. It'll be there. It'll be living there. So please spread the word so people can watch this and they have a more opportunity to be educated and get the information they need. And we'll keep doing the work. I thank you all from the bottom of my heart for this conversation. I appreciate it, and I wish you all a great evening.